Hello, everybody. Welcome to another case of AFR EMS case studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue. And today we are joined by our Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Hi, Doc. And we're also joined by Robert McGrath, our temporary upgraded fire lieutenant from Rescue 7 on this case.
Yes, sir.
Welcome, Rob. Thanks for joining us again. I appreciate it. So in this case here, you were assigned to Rescue 7 on an upgrade like we talked about, and on a non-preferred status, so it was you and you had an EMT basic driver. Is that correct?
I believe so, yes.
All right. And it sounds like you all were dispatched to a 23 Charlie, and that was to an apartment on Central for a 20-year-old female who was a suspected overdose. So pretty standard call that we go to regularly. Talk with us like what you're thinking on the way to an overdose call, like a 23 Charlie.
I remember going to that call, and right before that, we went on a separate 23 Charlie for a marijuana overdose, so which ended up being nothing. So then we were going on another 23 Charlie, and I wasn't too concerned on the way going there. I think just with the recent calls, nothing stood out in the notes, and we were just gonna run a regular 23 Charlie.
Yeah, absolutely, that happens. And you guys arrived on scene. What did you guys encounter when you first got there?
When we got there, there was some confusion because as we got there, they had a stage for PD, and then PD said that we could come up. And then when we got to the apartment door, PD was talking to other people inside the apartment, and there was a little bit of delay before we could actually go in. So things seemed to be changing pretty quickly.
Okay. And then when you guys were finally able to make access and encounter the patient, was she awake talking to you? What did she look like when you got there?
She was in the bathroom on the floor and was not able to talk to us or communicate, and she was kind of having what could be described as like seizure-like activity. And so we pulled her out of the bathroom and got her in the middle of the bedroom, and she still continued the seizure-like activity while trying to bite and hit us and things like that. So that was our initial observation of her.
And I'm assuming, was there other folks there, friends, family, who were able to kind of give you some brief history as to what was going on?
There was 2 or 3 young men there that were all fairly inebriated, and there was a lot of cocaine residue throughout the apartment.
Okay. And they had told you that she'd probably used cocaine throughout that day or into that night?
Yeah, they said they all had been, and they said that she had done 4 to 5 very large lines.
Okay. And so they called because she had done that and then collapsed in the bathroom and was kind of acting erratically, what you described as like seizure activity. So that's when they called for 911.
Correct.
Okay. Doc, what are you seeing on the hospital side in terms of, because cocaine, obviously, we don't hear about it as much. What are you seeing in the hospital in terms of cocaine use?
I feel like we've seen, and all of this is, of course, anecdotal, but I do feel like we're seeing a little bit more cocaine use in the city and around our system and in the hospital, in particular on some of the drug screens. And interestingly, you always worry with the street drugs. It's not like they're regulated by the FDA, so they can be cut or contaminated with a lot of other toxic materials that make them even more dangerous than they inherently are. So high doses of drugs or drugs that could potentially be contaminated with other substances really do pose a threat, especially for cardiotoxic effects.
Okay, it's good to know. So as far as our initial assessment, we were finally able to get her out of the bathroom. She's acting a little bit erratically, so you kind of have to help try to calm her down and de-escalate. Are you guys able to do a good, thorough initial assessment, and how did that look?
Not really, because she's moving around quite a bit and actively fighting us off. She's not able to communicate with us at all. We were able to get a 12 lead on her pretty quick, and we had already discussed kind of sedating her with some Versed. But when we got the 12 lead, I believe it came back as V-Tac.
Okay. So initially our heart rate was reading about 137, 152/88 for a pressure. She was satting okay, 92, breathing really fast, really amped up. Good capno, sugar was good. We're talking about Versed. We were able to get the 12 lead on, and we saw that wide complex tachycardias, which you saw on the monitor. What was your next steps after you saw that?
We did place pads on her after that. And then myself and the 5-5 medic had a conversation of whether to start cardioverting her or to try and treat with pharmacology.
Okay. And what did you guys do?
We went with treating with pharmacology. I felt that the Versed would calm her down and, in a sense, use the benzos to treat the cocaine's effect, and we should have the heart rate follow us suit.
That's great. Yeah. And we talk about these cases pretty regularly, right? When we have, polysubstance or just different uses of, we're seeing these typically lethal rhythms, right, that we've all been trained and doing our mega codes with. So we kind of jump to that initially, wanting to treat that rhythm with electricity. But sometimes we have to just kind of think through and take a second to say it's a 20-year-old, typically healthy individual. So it's probably just the drug. So we should, just because we can treat it, should we wait to try to do other modalities? And I think you did a great job by kind of thinking that through first. You talked about the cardiotoxic materials, Doc, but why is it important for all of these calls to do what Lieutenant McGrath did and get a 12 lead?
Yeah, so I think I love the fact that you took a second to stop and assess your situation and do things in the context of your patient, right? Because most people would look at this 12 lead and be like, oh yeah, you need electricity there, right? But that wasn't the right answer here. You had a lot of reasons to try your Versed first. First, you had a good blood pressure and was relatively stable, so we didn't need to cardiovert. And then, your benzos are going to help with three things. If this is a coronary artery vasospasm, it'll help relieve that. If this is agitated behavior, which it was, it will help with that. Right. If it's a seizure, your benzos will help here too. So you had a lot of good reasons to go with the benzos here before approaching the cardioversion, which was a tool in your toolbox, and you were ready for that if you needed to. But I think this is a classic example of why in every overdose you just assume that these drugs are cardiotoxic and get your 12 lead first. Historically, we were always getting 12 leads on overdoses, I think, to look for TCA overdose, and we could give bicarb there. But these days, with all the arrhythmogenic drugs out there, it's just wise to go ahead and just get a look at that 12 lead. Cocaine in large doses, especially in this case, I think could be the case with the 4 or 5 big lines that she did, can act as a sodium channel blocker, just like a TCA overdose. And you could start to see a wide QRS or even a longer QT. And in that case, you could treat with sodium bicarb or even magnesium if you need to, if it's leading to torsades, but treat it just like a sodium channel blocker.
Awesome. So we gave the first 5 milligrams of Versed. Did that help, or did we have to give more?
That helped. She did definitely calm down, and it correlated to her heart rate. Her heart rate dropped. We had a more unified complex, QRS complex. So we were headed in the right direction, and I'm not that familiar with that complex, and nobody else knew whether or not there was a elevator, and I think we were on the 3rd floor. So knowing that we were going to have to carry her down the stairs on the maker mover, we definitely didn't want her fighting us. So that's when we gave her another 5 of Versed for more of that sedative effect, and that also helped the heart rate also. I think by the time we had her downstairs in the back, she was in the sinus tac and resting comfortably.
Calmed down a little bit.
Yeah.
That's great. So got her to where you could do a more thorough assessment. Any changes when you guys got to the truck? Obviously, her presentation is now a little more relaxed. You're able to do a better assessment. Any other findings? Did you still see the same type of rhythm on the 12 lead?
With the last 12 lead we did, which I don't think we have here. I think it's a different one. But the last one we did had come down to sinus tac, and nothing was really standing out at that time.
Perfect. Okay. Did you guys have to participate in the transport, or was Albuquerque Ambulance able to handle?
after everything was said and done, Albuquerque ambulance felt comfortable, and I think they had a nice slow ride into the hospital.
Which, I mean, obviously, so they made the right decision to not jump at treating the rhythm with electricity or getting too aggressive with that, giving time for the patient to calm down, kind of get them to a more homeostasis state before they really made any decisions. And I think in this case, it was the right call. So you've hit on it a little bit, Doc, but with cocaine, methamphetamines, any of these poly substance that we're seeing out in the field, what's the leading cause of those, and why are they causing STEMIs and seizures? Why are we seeing that?
So these, we call them sympathomimetic drugs. So they mimic your sympathetic nervous system or really engage the sympathetic nervous system. So we're seeing people with really fast heart rates, really high blood pressures, really fast respiratory rates. Maybe they're sweaty, flushed. And the answer for that is to kind of balance out. Our bodies need homeostasis, and so we, in order to balance out the sympathetic nervous system, we give the benzos to kind of help bring down that level of sympathetic activity. The other thing you could consider is some fluids. There's a lot of insensible fluid loss that goes with that, but it sounds like her pressure stayed stable, her heart rate came down to acceptable ranges, and I'm sure they probably gave her a bolus on the way into the hospital. What I really like, what you did here, is a lot of people would see that initial 12 lead and maybe have a little bit of internal angst and be in a hurry to leave. And what I'm really excited to hear you do is you took time to think about your options to stabilize her on scene, and you fixed it by the time she got in the ambulance. And I think just because you see a scary rhythm doesn't always mean you need to rush. I think sometimes the wiser thing is to slow down and think, and then be like, I can handle this. And there's times to rush, but there's also you're well equipped to handle these emergencies, and you did a great job here.
Thank you.
We talk about that regularly outside of trauma and being in a surgical bay. There's pretty much everything that they're going to do in the hospital, in the ED, we can do on scene. So I'm a big proponent of hanging out for a little bit, get everything solidified, have everybody in an identified role, treat the patient once everything's kind of calmed down, and then you can make those decisions, which is, you guys hit the nail on the head with this, and it was perfect treatment for this patient. So great job. And we've talked about it before, like upgrading into the position, going to be an LT soon, but talk to us about what you would do differently, if anything, or how you would educate some of our newer paramedics who are going to sit in that officer role when they encounter this call type.
I think one of the biggest things that I should have done differently is I should have called for help. I never asked for an engine or other units. And that might have been kind of how the night had been going, that I didn't see this call becoming as serious as possible. So I kind of got some tunnel vision on that and should have asked for help. But remembering that our uppers can be treated with benzos, I think would probably be the thing I try and pass on.
Yeah, fantastic. Well, I appreciate you taking the time to come and share this case with us. If anybody has any other interesting cases and wants to come talk to us about it, if you go through SharePoint, you can make the a submission there, or you can reach out to anybody in the EMS division, and we'd be happy to have you come down and discuss the case. Until then, we'll see you next time. Thank you, everybody.